I'm Dr. Neil Skolnik, and today we're going to talk about the 2023 Non-Hormone Therapy Position Statement of the North American Menopause Society, or NAMS. This is important because up to 80% of menopausal women have hot flashes and night sweats called vasomotor symptoms, and they last a lot longer than many of us appreciate, with a mean duration of 7 to 9 years, interrupting activities, interfering with sleep, and diminishing quality of life. In a third of women, vasomotor symptoms can last longer than 10 years. So this is an important issue. While postmenopausal estrogen therapy is the most effective treatment for VMS, it's considered first-line therapy. Many women and many practitioners are concerned about the evidence-based adverse effects of estrogen therapy, and so choose not to use it. For women with an intact uterus, which is most women, estrogen is used with progestin to prevent endometrial hyperplasia and cancer. The risks associated with estrogen therapy include an increased risk of venous thrombosis, that's DVT and P, and most concerning to many women, an increase in the risk of breast cancer. This increased risk of breast cancer is in the range of 30 to 60%, and even up to 100%. That's a doubling of the risk. Those numbers depend on which data set you look at. See the references below, particularly the collaborative group on hormonal factors in breast cancer published in Lancet in 2019. The risk increases with the duration of hormone use. The effects on developing coronary disease have been debated. The benefits of estrogen are also there and include a decrease in genitourinary symptoms, as well as a slowing of postmenopausal decrease in bone mineral density. Because of the concerns that many women have about the adverse effects of hormonal therapy, and because some women are just not candidates for hormonal therapy, it's important for us to understand non-hormonal options for the treatment of VMS. In this regard, there are some things that work and some that don't. I'll go over lifestyle and dietary interventions first, then supplements, and finally, prescription medications. In each category, first I'll go over the things that work, and then those that do not have demonstration of efficacy and so are not recommended by NAMS. Let's start with lifestyle modification. Recommended as effective are weight loss, which decreases the frequency and severity of vasomotor symptoms, CBT, which decreases the degree to which VMS is bothersome, though it doesn't decrease the frequency of VMS, and surprisingly, hypnosis, for which there was a randomized trial showing a decrease in the frequency and severity of hot flashes. Not recommended due to a lack of evidence of efficacy are cooling techniques, exercise and yoga, dietary modifications, mindfulness interventions, paced respirations, relaxation exercises, and acupuncture. Now, throw out that if an individual finds one of these things helpful, I don't see a reason to discourage it. You can't argue with general health benefits of exercise and yoga, for instance, but none of these have demonstrated clinical trial evidence of efficacy for VMS. Let's now talk about supplements, which are commonly used, but which there is not much in the way of well-done clinical trials to support their use. So the guidelines do not recommend them, and that means they don't recommend the following: soy derivatives, pollen extract, ammonium succinate, lactobacillus, rhubarb, black cohosh. Remember, black cohosh is the most commonly used botanical for VMS, but it also has reports of hepatotoxicity, so we do need to be particularly careful there. Evening primrose, vitamin E, as well as some others. Let's now go on to discuss medications. Among prescription medicines, there are 2 FDA prescription medicines: paroxetine at a dose of 7.5 milligrams daily, and fezolinetant at a dose of 45 milligrams daily. Fezolinetant, approved this year by the FDA, is the first in a new class of medications. It is a neurokinin B antagonist, which works directly on the thermoregulatory area of the brain, targeting the neural mechanisms that cause VMS. It is little in the way of off-side effects, though liver enzymes need to be checked before starting the medicine and periodically thereafter. Fezolinetant decreases both the frequency and the severity of hot flashes and improves both sleep quality as well as quality of life. Paroxetine, at a low dose, 7.5 milligrams daily, modestly decreases both frequency and severity of hot flashes, along with improving sleep disruption. Among the non-FDA approved medicines that are recommended based on evidence are SSRIs and SNRIs, gabapentin at a significant dose, 300 milligrams TID or higher, and oxybutynin. The NAMS recommendations do not recommend using pregabalin or clonidine. So in summary, we're fortunate to have some non-hormonal, evidence-based approaches to vasomotor symptoms that work. There are 2 FDA-approved medications, paroxetine and fezolinetant. There are non-FDA-approved medicines which have evidence of efficacy, SSRIs, SNRIs, gabapentin, and oxybutynin. There are also non-pharmacologic approaches, including weight loss and CBT. Vasomotor symptoms are common for women going through menopause and postmenopause, and there's a lot we can do about them. The guidelines offer very helpful advice. I'm interested in your thoughts. Please leave them in the comments section below. I'm Neil Skolnik, and this is Medscape.